We will go ahead and get started for this morning for our MGH Global Health Grand Rounds. I'm Garen Stone, I'm the Global Medicine Program Director, and it's my privilege to welcome you to this month's MGH Global Health Grand Rounds. We have the honor and privilege of having Dr. Rupa Dutt with us, who is the Executive Director of Women in Global Health and a practicing internal medicine physician at Georgetown University Medical Center. Described as a fearless and great health diplomat, Dr. Dutt is a passionate advocate committed to addressing issues of power, privilege, and intersectionality that keep many women from global health leadership roles and to opening up spaces for the voices of these women to be heard. Determined to build a movement to transform women's leadership opportunities in health, Dr. Dutt co-founded Women in Global Health in 2015. Today, Women in Global Health has more than 25,000 supporters in more than 90 countries and continues to grow. Women in Global Health focuses on supporting a diverse group of emerging women leaders, engaging global health executives to transform their own institutions, and growing the movement for gender equity. As she made touch on this morning during the COVID pandemic, during last year, Dr. Dutt has been very busy. She's helped highlight the reality that a disproportionate number of frontline workers are women, and was part of a team that evaluated the language used by men and women political leaders during the pandemic. And in March of this year, she signed a memorandum of understanding with the WHO Director General with the aim to further the shared goals and objectives of women's economic empowerment, gender transformative change, and universal health coverage, and the health workforce on a global level. It's our honor and privilege to welcome Dr. Dutt to this morning's Global Health Grand Rounds, and I'll turn it over to you. And at the end of the session, we'll have a moderated question and answer period.
Great. Well, thank you, Dr. Stone, for such a warm welcome, and it's such a privilege to be with all of you and be among colleagues that have been so dedicated to addressing global health and inequities already. And so I feel like I'm already speaking to a room that's going to really already understand some of the challenges that we're facing to truly achieve a gender equitable and diverse global health leadership community. And I'd like to kick us off first before I dive in is just sort of stepping back and imagining the world from perspective of how global health currently looks like. But let's pretend we're in a hypothetical country where 50% of the population has brown eyes, 50% has blue eyes, and in that country, 70% of the health professionals have blue eyes, and health is considered a blue eyes profession. But 75% of those leadership jobs in health are held by people with brown eyes. How does that compute? So I'm going to just repeat that again. In a country where it's 50-50, 70% of the professionals have blue eyes, but health is a blue eye profession, and yet 75% of those leadership jobs in health are held by brown eyes. And so that's really what we call the 70%, 25% paradox in global health. And this is the leadership pyramid that I'll be talking about. And with a level playing field as this profession, how is it that we can have 70% of the field of women, and why don't we have 70% of women at top leadership roles? Of course, there are exceptions in certain communities, but for all of the global disaggregated data, regional breakdowns, and at the country and the national level, we keep seeing this play in and out, and COVID-19 really hasn't been any different. I'll also be talking about the talent pipeline. We don't have a talent pipeline issue in the same ways that many other sectors do. We have a lot of women that do come in to medicine, public health, global health, but what we have is a leaky pipeline. And some say this leaky pipeline is not just a holes where women are falling through, but it's actually an active force of pressure forcing women out for a variety of reasons. A recent paper that was published in BMJ looking at the country of Canada showed for the past 25 years, men and women have been graduating at equal numbers from medical schools. And when you take a look at the leadership roles, again, we see the exact same scenario where women are underrepresented in senior leadership roles. And the reasons that they cite are barriers beyond the fact of confidence, but it's actually issues related to facing sometimes violence, harassment, pay issues, and I'll be covering some of those trends, just to say that it's not just about the numbers, but it's also about the enabling environments. And so gender equality is always a work in progress. And I'd like to begin with just sort of getting a, assessment in the room of what people think, how close are we to achieving gender equality. And if I believe the chat function is something, Dr. Stone, folks can use it. Great. So let's say if we are estimating how many years it's going to take us to achieve gender equality, and really looking at the 4 pillars: economic, education, opportunity, and political power. How many years would you say it's going to take to achieve gender equality? And please don't be shy. Just if I use the chat function, it helps me assess, what the range is, and guess what the median is. And then while people are doing that, I'm going to actually pull up my slide deck here. Okay, I see a couple of estimates here. I'm going to give a clue. If you try to go much higher. Great, we got 100. So that's the game. It's getting warmer. All right, we got 150. Well, these are definitely in the right range. And right now, by the World Economic Forum, the guess is it's going to take 139 years for us to achieve gender equality in all those aspects. And just to show you how quickly this can shift, when we started Women in Global Health, the guess was that it was going to be 207 years by their modeling. And to show you the year before, it was around 100 years. And so the pandemic, COVID-19, has actually widened that gender inequality projection from the World Economic Forum. It was really exciting when it broke near 100, and now we're back up to the the 130s and 140s aspect of it. So it just shows you that the first guesses that we had was the lower spectrum. And what I found is that when I'm speaking to communities that guess in the lower numbers, they tend to often be in places where there is a lot of gender parity or women in leadership roles. So, I have to admit, I've already been told that you guys do have very fair representation in your program. But what I've also noticed is in communities which have women that have been practicing in the global health space for over 2-3 decades, they tend to guess lower numbers as well. The fact that it's going to take us much longer to achieve gender equality. So on this note, I'm going to ask for some technical confirmation that folks can see the slide deck here. Great. And so I'll be focusing today on gender transformative leadership, a pathway to equity in global health. So the objectives for today's conversation is to really summarize the challenges and barriers to gender equity in global health leadership. I'll be providing some examples of what gender transformative leadership looks like, and I hope to share some examples that your community would find useful on how you can actually transform global health to be more equitable. So citing some examples from the last few years of our work. I've been really already introduced with what Women in Global Health is, but just, in a nutshell, Women in Global Health, we are a global movement that's striving to challenge power and privilege for gender equity in health. And we call ourselves a global movement because we first started as a group across borders, intergenerational, without any formal organization backing us. And I'm one of the 4 co-founders who actually went to the World Health Assembly and started at a coffee table in 2015 and connected through social media platforms such as Twitter to form Women in Global Health. And now we've grown to have 50,000 supporters in 90 countries with 24 official chapters and 52 estimated by 2022. 63% of our chapters are in LMIC countries, but we really like to point out that the movement is global and universal. We have a strong presence in the United States and in Europe as well, and hoping to have a Boston chapter, in which I can come to at the tail end of this conversation. And so this is just a geographical map showing where we have chapters and where we have pipeline. What's been really amazing is that during the COVID-19 pandemic, we've actually doubled in numbers, and I'll come back to that. So we are a global movement, a platform for all voices, so men and other genders engage in our platform as allies. We're a catalytic force, so really bringing the conversation of gender equality where it isn't happening, and we consider ourselves a strategic disruptor because we particularly target organizations such as the World Health Organization, which is one of the most influential global health actors to drive the change, working with key governments and donors to, again, bring this change over. And depending on the window of opportunity in the policy space, that's another way that guides our approach at Women in Global Health. This is the team, and I just wanted to point out that we are, we are a all 100% women team, but we do have, again, men as leaders in our chapters and engaging throughout the movement. We are intergenerational and also geographically based everywhere. So the virtual world was not new for us. And so I think that is also one of the reasons that Women in Global Health was able to mobilize in the past year. And so another approach that Women in Global Health really does is that we consider ourselves doing things differently. And for us, when we entered the gender equality space in global health, we really entered a area where these conversations were quite not happening in 2015. There was clearly a commitment to addressing social determinants of health, issues of health equity, and we are a field that's very committed to looking at those issues, but looking at how power is distributed in leadership and decision-making in global health at that point in time in 2015 just wasn't a normative conversation. And so we started bringing these discussions from the very beginning with a power lens, and I'll be covering that a little bit more in detail. But what we mean by approaching it with a power lens is that we're looking at things from gender, race, geography, age, ableism. Some refer to this as intersectionality, but for us from the very beginning, looking at where power in global health is was not only the right thing to do, but the smart thing to do. Those that are the most affected by the global health challenges and the communities we're trying to reach, and where a majority of the global population aren't necessarily represented in leadership roles, and I'll be talking about that too. We also designed our work, our advocacy, our campaigns, programs from the very beginning, with making sure that it was really the women that were the least represented in global health that were having the opportunities and the platform to shape global health discussions. So for us, hardwiring equity was part of our core values from initial aspect. And just to kind of share what that looks like is when Women in Global Health started in 2015, it was in 2018 that we started having chapters, and it wasn't actually driven by a global team, but two communities of women, one in Germany and one in Somalia, spontaneously started connecting and forming their community of women in global health. And they actually approached us a couple months after they had already started connecting with each other, saying, we want to be a chapter. How do we become part of the official global movement? And so we weren't planning to have a chapter model, but it was something that spontaneously happened. And it was, again, a country like Somalia, which has 5 governments operating, a fragile state, or one could argue is still in an active stage of war, coming together, these women, with a proposal and already having connected, and then a high resource setting as Germany. And again, this is, an example of the grassroots aspect of Women in Global Health. And just to sort of discuss some of the language, the words that we're using, one word that you're probably familiar with is really, in the spectrum of looking at gender and addressing gender is being gender sensitive. What we're really trying to do is get to gender transformative. So if you take a look at the starting point, gender unequal is a situation where actively a program, organization, a community, or the environment is perpetuating gender inequalities. This is where privileges are given to men over women. One sex has more rights than others, and there examples are there are countries where women are limited, that they cannot hold occupations that have late night hours or night shifts, or some countries have laws limiting what professions women can hold. And so that's an example of being gender unequal and exploitative. And there's many more, but just for the sake of simplicity to articulate that. And then gender blind, which in global health, we still are seeing a lot of programming, even during COVID-19, where there isn't an acknowledgement and there's a blatant ignoring the gender norms and roles. So an example is talking about health workforce issues, but not acknowledging the fact that it is a majority female workforce. And often it is also about reinforcing gender-based descriptions. So language saying, well, women like to care, so therefore they like to be nurses, and they don't need to be compensated because as health workers because they like to care for their community. And reality is women also like to have economic autonomy and decision-making power, and those things are left out, and that's an example of being gender blind. And then where there's gender sensitive, where there is consideration of the differences, but not necessarily addressing them. And then gender responsive is where there is a acknowledgement and also aspects of the programming which addresses specific needs based on gender, the needs of men and women in accessing health services, acknowledging, for example, there needs to be a maternity ward for women, and there needs to be targeted ways of designing healthcare services to reach girls and women. So that would be being gender responsive. It is also about considering barriers and access to resources. So in many countries, women don't have the same amount of financial power, and so acknowledging that care, especially for in the family planning phase part of it, or for access to sexually reproductive health, needs to acknowledge that women might not have the ability to have money to access services, or even the decision making to get in some countries to even get a cervical exam done by a GYN requires the husband's permission still today, so informally or formally. So these are examples of where programs would accommodate that. And then gender transformative, what I'm making a case for today, and so does Women in Global Health from the start, is not just acknowledging these things and starting to address them, but really looking at the root drivers of these gender inequities in the health space, and aiming to foster change through looking at power relations between genders and making sure that women have equal power as men, and also acknowledging that gender is a spectrum and there are underrepresented communities within. And then going further into gender transformative leadership, this is really about the practice that happens at the individual level and happens at the organizational level, and particularly making sure that there is an assessment of power and privilege, who has access to resources, how close are they to those resources, and what decision-making power do they have, or influence do they have, and whether that is earned or whether that is by default, given the fact that you're part of a privileged group or privileged community. Taking a look at intersectionality, again, I alluded to this, but going beyond gender and looking at the different identities and acknowledging that this also changes based on the context, being intentional about being inclusive, and looking at leadership at all levels and forms. So not just formal leadership titles, but also leadership at the community level, organizational leadership. And again, the goal is to achieve gender equality and women's rights, and acknowledging that this is a progressive realization. Individuals and organizations might be at a different part of the journey. It's a work in progress. And the bottom line is that we do this not just because it's to advance gender equity, but it also leads to better health equity. And this is sort of the gender transformative leadership. And if you're keen to learn more about it, please do reach out and I can give some background paperwork. And it comes from the School of Thoughts formed by gender equality, but also transformative leadership. And so I'd like to shift now to convincing this group, which I know I don't have to, but again, there is a power in data, and what do we know now in 2021 as well in 2020 about what global health leadership looks like. And so one of the very first exercises that Women in Global Health started doing in 2015 was trying to identify key areas of global health that we felt had the most influence, and contrasting it with the workforce numbers, and to see where women's leadership and power and influence looks like. So we call this the leadership pyramid. So again, global health is delivered by women, but led by men. 90% of the long-term care workforce are women, going up this base of the pyramid. 70% of the health and social care workforce are women. And then when we start looking at political decision making, what we've found is that ministers of health, of those that represent governments at the World Health Assembly in Geneva at the WHO, those numbers are around 23%. And these are numbers that are compiled between the years of 2018 to 2021. Looking at deans of top public health and medical schools and academia, again, those numbers around 30% at 28 this time. And then another number which is being tracked is heads of global health organizations and board chairs of global health organizations. And this data looks at 200 organizations. That number has been stagnant around 31%. And then the private sector, which is also a key actor we don't often acknowledge as part of global health without being intentional about it, but the Fortune 500 healthcare companies, less than 5% have women in senior leadership roles as CEOs. And so this is the pyramid of global health leadership that is often referred to and cited in the UN by WHO. So this is something that Women in Global Health is constantly looking at. And then other aspects of like women's contributions to the health sector, looking at data that's been coming by health economists. Currently, women contribute $3 trillion to health annually. We are projecting that these estimates will have increased in the pandemic year, and half of that is currently in unrecognized and unpaid work that women are doing as informal health workers or informally being caregivers that is not currently being counted. And this is data from the Lancet Women in Health Commission, where the research group was based in Harvard. They're working on doing another set of projections that we hope to see hopefully by later this year. But as I've talked to some of the health economists who are working on this, they estimate these numbers to at least increase by 30% even just in the past 5 years. And then breaking it down by region, particularly, there's a lot more data around this, but I just focused on one number, which I think is really telling, is who heads the World Health delegations to the WHO World Health Assembly in Geneva. And we've looked at this number back almost 15 years, but giving a snapshot on last year, where it was a virtual World Health Assembly, what you'll notice is the number again is 23% for overall delegates. And taking a look at the geographical spread, there's some regions that clearly are further behind, and that's the Western Pacific region and the Eastern Mediterranean region. But what is also surprising is that there's a notion that European countries are doing better in gender equality, but even in the Euro region, we didn't break 30%. There's no country that or no region that geographically had greater than 30% representation. And again, this is a virtual assembly, so it means that women often are one of the reasons that's listed as barriers for women's representation is that women have care responsibilities, so they can't leave their home, and so therefore, or they can't, travel as much. So that's why they are not represented. And we actually had expected these numbers to be higher, given that the World Health Assembly also happened in May, and at that time there was already a lot of acknowledgement of head of governments that were women doing well with their response. I should acknowledge that World Health Assembly did have many women head of states attending for the first time, but those numbers were not matched by women leading delegations, and those delegation leads are the negotiators. They are often the decision makers and have the most political power in global health decision making at a member state level. And this is the data where we went back to 2005. And what it shows is that, the peak was around 2017, where we saw the data peak at 31% of chief delegates. And what's interesting is that this was around the time that there was a acknowledgement and actually formal language written by the WHO Director General to governments to have gender parity in their delegations. And we can't, say as a hard fact that the correlation, but the fact that there was intentional language in the letters going out to delegations that likely influenced, and that also happened in 2018. We're not sure if the same language is included in 2019, 2020, but there were, probably many other drivers. But 2017 was really the first time there was an active effort to make sure that we actually have a gender parity in member state delegations by the head of the organization. And so now I'd like to turn to additional data that's been provided by a group called Global Health 50/50, and it's a research entity based out of London. I really recommend you to check out their website. They have a very interactive data tracker and have been releasing reports since 2018 on gender parity and other gender equality indicators, looking at 200 organizations in global health. They do use a very broad definition, so I want to acknowledge that this data includes private sector companies that many people in global health would not consider actually global health organizations, so oil companies and certain larger food production companies, and that's because the definition they used is any organization that's committed to Sustainable Development Goal 3 is an organization working on health. So I do want to ground that there are some factors in the data that limit how many of us, including women in global health, view the data, but it's still valuable in the fact that they've been tracking it since 2018. So 50% of the global health leaders of these 200 organizations are from two countries, the United Kingdom and USA. So they did a geographical analysis. They also found that 17% of the CEOs and board chairs are from lower middle income countries, and looking at the data for particularly women leading from LMIC countries, those numbers went all the way down to 5% of global health organizations are led from women from LMIC countries. And if you contrast that to the world's population and also where global health programs are targeting their efforts, 83% of the world's population is based in LMIC countries. So this is a very stark example of where we have our majority of our work happening or target of our work, and how little of that work actually is influenced by those that have a deep understanding of lived experiences and realities. And again, if you look into the data that they have collected, there are other examples of how majority of those people that are leading global health organizations are educated, again, in a high income country setting institution. And so again, the institutional knowledge and approach shapes decision making too. So it's just showing how limited diversity we really have in thinking and geography as well as gender. They have also released a report in 2021, which goes a little bit deeper into realities in COVID-19, but I think their 2022 report will be really exciting since they will have had more data looking at COVID-19 more broadly, and where some examples of the data that they've already collected is less than 30% of organizations in global health disaggregate data by sex and gender, and they break it down by sector, and it's quite a fascinating reporting system. And so based on their modeling, to really contextualize this, so if you are a CEO and looking at their sample and you're a male, you're 3 times more likely to be a CEO. If you are educated in a high income country, 13 times more likely to be a CEO in global health. And this is, I think, a really nice way to just show the power at work and how power multiplies. One of the other examples here is just how exponentially one can gain power. So if you're a CEO of an organization wielding for-profit power, so private sector, you're 40 times more likely to have complete education in a high-income country. And again, the private sector is one of the most stagnant in the health space. And looking at it from an issue perspective, they also mapped out global burden of disease data and compared how many of those issues, particularly also look at Sustainable Development Goal 5, which is about gender equality and women's rights. Some of the top agenda issues are universal health coverage, and only half of those organizations working on universal health coverage have gender equality aspects to it. And then when you take a look at health workforce, which I'll be doing a deeper dive on, and only 30% of the organizations look at gender in their work intentionally as part of and working on SDG 5 as well. What is also interesting is that 100% of the health workforce organizations look at gender really from the experience of women, not necessarily approaching it from a gender lens where you're factoring in men and all other genders. Another example of recognition and women's recognition in the health sector, we did a review in 2017 looking at the top public health and medicine awards. And again, this was a very limited data, but what we found is that if we went back about 100 years from all the awards that have been given, we looked at a few different countries and some prominent awards around the world, that women had received less than 10% of those awards. When we backtracked the data for just 10 years, that number was 17%. And so again, recognition is a key aspect of career projection, and women are not receiving as much recognition. Many of these awards were not just about recognition, but they also had monetary aspects to it. So awards such as the Gardner and the Prince might all give very large awards, and what we can see there is those percentages around 6 to 9%, and they have unfortunately not changed. I have to say that Gardner Awards is actively and very intentionally linking up with universities to encourage diverse candidates, and particularly women, to be applying. And so this is another way that your community can help address some of the gender gaps, is really making sure that the talented women that you work with are supported to apply for these awards or being nominated for these awards, because they do bring a lot of recognition, but open up many more doors, and again, bring women from just practicing global health, but into recognized leadership, thought leadership roles. And so how do we really drive gender transformative action? So I'm going to be covering 2 examples. I'll be going through this a bit quickly because I want to make sure we do have time for Q&A. And again, going back to what gender transformative means is that we're looking for the root drivers of inequities and making sure that we're creating solutions and approaches that address the root drivers of these inequities. And this type of change does not happen in short term. It is clearly change that takes decades. As we know, the estimates for gender equality are already over a century long. And so Women in Global Health, our approach to driving change is that we see ourselves as catalytic, and catalytic at the global and local. So when we see that there is an area that is currently not getting enough attention in gender equality, particularly when it comes to leadership, whether it is a field or whether it is a specific area within global health and issue-based, or whether it's the entire reality such as COVID-19, where we launched a campaign. We work with member states and target global health organizations that are the most influential. We are specifically focused on global health organizations as most influential that are part of the UN and multilateral, since they're the norm setting and they work closely by member states. They're shaped and influenced by it. And we use this to really set the agenda at the global level. We create technical products such as policy papers and reports, provide technical advice. We work on influencing the language. So every UN meeting, for the most part, will have some sort of agreed upon document. Sometimes it is a high-level political declaration. Other times it is a set of commitments that have been agreed upon for that particular meeting, or resolutions. And so we focus our energy on key ones that we feel like will shape the field significantly. And then we also try to get these organizations to not only work on gender equality and do what's called gender mainstreaming, making sure that all of their programming is looking at gender, but have them look at their own organizational culture and model good practice at all levels. And this is actually one of the toughest things to do in these organizations. And then we use member states to actually put the pressure in at multiple levels. And we use our chapters at the local level to push pressure on governments and member states to drive this change. And so this is the systems approach to driving policy change for women in global health. It looks probably very familiar to other models that are systems-based and approach policy change. And through using this approach, some of these things were already highlighted in my introduction, but our impact has been, this past March, we have been able to sign a memorandum of understanding with the WHO, where we're particularly working on gender equality in their organization and in their programming. Our work influenced the very first resolution that passed on COVID-19 at the UN, at the World Health Assembly, where 3 of our key policy asks around gender responsive health security were integrated into the resolution, and that required working closely with member states and our chapters. And we've also been able to really, when gender blind work was happening in COVID-19 response, we've been able to get 40 plus commitments from governments on being gender responsive. And I'll cover briefly some of these examples. So backing up to March, which it feels like a very long time ago, and at the same time feels just like yesterday. And March was when the pandemic was announced. Women in Global Health quickly mobilized, even as early as February, when we started seeing that women's voices and perspectives were being left out of decision-making, out of media, we were hearing reports from our colleagues in academia that they were struggling to publish as much or even get grants. We started mobilizing through our chapters and have had over 100 plus virtual events, workshops, engagements from all of our chapters to really make sure that women's perspectives was not left out, and that we would really start having a gender responsive approach. We used data to make the case. Women in Global Health did a review looking at 115 countries and their task teams, and what we found is that 85% of those national COVID-19 task forces were comprised majority of men. We also found in doing this exercise that decision making at in many countries was not transparent. It was really difficult to know who was in these task teams. It really took word of mouth. Very little data was available in the public sphere, even when we worked with locals or public health and global health people that were had close ties to these countries. And we also noticed that while there was a limited review looking at the response of female leaders being more successful at managing the coronavirus, over and over again in the global health sector and at the subnational and national level, women were being left out. And while there was a clear acknowledgement of women's power is out there and that women are doing quite well in many countries, some estimates were showing that countries led by women were outperforming at 6 times in suppressing COVID-19 virus spread. And this is back in July 2020, where that review had come out. When we broke this down by region, what you'll notice is that I want to point out two main regions I'd pointed out before. We already knew that Eastern Mediterranean region and the Western Pacific region was not doing well, but what you'll notice is that Eastern Mediterranean region, the 9 countries we looked at, 100% of them were all male in every decision-making role in a task team. In the Western Pacific region, those numbers were much better. So the story was consistent, but in some ways even worse than what we had imagined. And places where we expected it to be much better, such as the Afro region, and more than 90% of the task teams are majority men there. So COVID-19, in a way, should have become an opportunity for more women who are at the front line to be part of these decision-making bodies. But again, we saw it play out that gender inequities worsened in leadership as they have in previous disease outbreaks. And we know that had an impact in policymaking, particularly gender-blind decision-making. WHO did a review looking at what health services were disrupted, and of the countries that responded to their survey, 30% of countries reported a disruption in maternity and reproductive health services. And what we found out in our network is it didn't matter whether you were in Germany or in Nigeria, women were being told to deliver their children at home or their babies at home. And this just, again, is a reminder that we're very confident that if women were in equal numbers in these decision-making bodies, they would not assume that women are not going to get pregnant. You've also probably heard about physical personal protective equipment being modeled on male bodies, which in many countries meant oversized suits or not the appropriate size face masks, and many of the women health workers having to modify, and many of them did not even have access to PPE. There was also issues of having bodysuits that were designed in a way where it was very difficult to get out of them and to meet the bodily biological needs of women. So when women were menstruating during the pandemic, example is Wuhan, the UN agency called UNFPA sent out dignity kits to Wuhan, China. We also know that lockdown policies resulted in increase in gender-based violence and violence against women. And again, many of these policies were done blindly without acknowledging the fact that for many women and children, they would be in households where they would be at greater physical violence risk. And so these are some examples of gender-blind decisions. Women in Global Health launched a 5 Ask campaign. You can learn more about it at covid5050.org. But in this 5 Asks, we really used clear messaging and focused our efforts on 5 things we wanted every organization, every government to do, which clearly included making sure that women are included in decision-making, looking at safe working conditions, recognizing women's unpaid care work, adopting a gender-responsive approach, including disaggregating health security data by gender and broader aggregates, and then and also making sure that we were funding women's movements at the grassroots who were really critical in building resilience where health systems were falling apart. Some of the other activities we did is we launched a Operation 50/50 list, which was a open crowdsourced way to create a roster of 100 women experts. This was used by New York Times, CNN, and a few other mainstream news media channels to make sure that they were reaching out to women in equal numbers. The first review we did at women being cited in media, it was 1-to-4 ratio, so men were more likely to be invited for media interviews. And so this was our immediate response that we did in March, and we have over 100 plus women from around the world in this list. We did a big summit to garner and mobilize around UNGA, launch a report to make the case again for the gender inequities, and then we're able to get commitments from over 7 governments, many of them like the key drivers of the gender or key drivers of the COVID-19 response at the global level at WHO, and we engage many of the multilaterals that are part of what's called the ACT-A accelerator, the mechanism for addressing COVID-19 at a global level. And we also worked very closely with other partners, and all of these groups made concrete, measurable commitments to include gender in their COVID response. I'm realizing we're almost at time, so I'm going to give the second example, and these slides will be available for all of you to dive in deeper. And if anyone wants to discuss the issues further, I'm always available to clarify. So now diving into health workforce, where Women in Global Health has done a significant amount of work. We launched a report in 2019 with the World Health Organization looking at the challenges that health workers face. We are particularly focused right now in this acute phase on leadership, and we will be launching a policy action paper at the World Health Assembly, which is really targeted towards how do you drive gender transformative change in the health workforce. And so key messages that were found in the 2019 report is we know that gender stereotypes, discrimination, and power imbalance is a key driver in the health workforce. We also know that disadvantages for women intersect with other identities, and this is the intersectionality aspect. And we also know that global health is weakened by excluding female talent, ideas, and knowledge. And women leaders often expand the health agenda to strengthening health for all, not only focusing on women's issues, but also having a more holistic approach. And we know that gendered leadership gaps in health is a barrier to achieving SDGs and universal health coverage. We modeled through looking at over nearly 200 peer-reviewed articles and gray literature and other focus group data to come up with what are some of the barriers that women in the health workforce are facing. And examples are there's challenges at the individual, and that's what the conversation often stops, that women need mentorship. And we often say it's not about fixing women, but it's about fixing systems. And we really tried to take the conversation based on the data that we found that it is much more about the institutional factors, the interpersonal factors, which is sexual harassment, introducing paternity and maternity leave, community factors, like really addressing how society views men and women. And for example, 50% of society in 75 countries think that men are better political leaders. And even in countries like the UK, those numbers are sometimes even higher, that where you would expect a country dedicated to gender equality work for decades, that those numbers would be better. And so this is our way of saying, take the conversation beyond the individual factors. And too often programs focusing on mentoring and assertive training, negotiations, that's all important, but we really need to go beyond that. This framework, which will be released at the World Health Assembly in just a couple weeks, we really talk about the 4 actions of areas. And if your program is looking to work more deeply in these issues, especially not only where you're practicing, but also relationships that you have with other global health communities and programs around the world, we really say that, the 4 action areas to drive the leadership changes: building a foundation for equality, addressing social norms and stereotypes in that program, really working on fixing the workplace systems and culture and not women. So actively looking at what are those structural barriers, including targets and quotas. That's actually been proven. The only proven policy that UN Women really pushes for to achieve gender equal leadership and enabling women to achieve. And this does include fostering both formal and informal networks for women's leadership, but also having allyship networks, which are where other genders support women as well. If you want to get involved specifically in these issues, where we work with the World Health Organization, we do have a community of practice called the Gender Equity Hub. It's, again, co-chaired by WHO and Women in Global Health, and please do reach out if you'd like to engage with that. And as I come to the close and wrap of the talk, 2021 is a really exciting time period. It is 26 years since the Generation Equality Forum is celebrating the Beijing Conference for Women, which is the first time in 1995 where governments came together and really made a commitment to women's empowerment and leadership and gender equality. And as a result, there is commitments, opportunities made for all type of actors, not just governments, but civil society, academia, private sector. Any entity can make commitments before the June forum in Paris on how they plan to advance gender equality across 6 action coalitions. It's also the year of the health and care workers announced by WHO. So there is political opportunity to mobilize this. And of course, COVID-19, the silver lining is everyone is looking at how to build stronger, more resilient health systems, have pandemic preparedness. Every country is looking at its national health workforce plans, national health capacities, and this is the time to really make sure that they aren't gender blind plans. And if you'd like to learn more about an initiative that Women in Global Health is doing with the government of France, you can look up Gender Equal Health and Care Workforce Initiative. And in the slide deck, I have shared a couple of highlights about the issues we're working on, and we are going to be mobilizing commitments the way we did with the COVID 50-50, and really aiming to launch a long-term initiative where there's accountability and we're measuring progress on the road to the SDGs, which is meant to be achieved by 2030. And again, these are many of the issues I've already covered, but we're more concrete on what type of our asks are and what we're asking governments, as well as other stakeholders in the space to help us achieve this agenda. And again, every time we do make a case, we always lead back to that it's not only the right thing to do, but it's the smart thing to do. And in this case, we really make a case for the return on investment when you have gender equal health workforce. And these are, again, points of specifically the key features. And for those that are really keen to learn about driving policy change, I recommend you glancing at this slide. I do want to create space for Q&A. And we've outlined our approach for the year and key milestone time periods. And what I wanted to point out here is that there's a mix of events and engagements where we try to drive policy change, engaging governments, engaging civil society, using existing platforms for policy change, and leveraging them as well. Again, we invite all of you to also participate, as it's for global health leaders to make sure that there's awareness about this initiative, but really to look at how your organization can make a commitment, or if there's governments you're working with, to encourage them to really look at making a commitment to this initiative, which we again announced in June with President Macron being the main endorser of and host of this dialogue. There are a lot of issues to watch in 2021. I did want to emphasize that there is conversations inspired in many ways by Black Lives Matter, but also by decolonizing global health. And this is an emerging area, but Women in Global Health, we have been looking at this, and we encourage all of you to go beyond looking at gender and really having intersectionality aspect. And again, this is food for thought, and these slides will be shared. So I'd like to turn it back to all of you. I know we went through a lot, but really invite you to join the Women in Global Health movement. We do have a community of people organizing, mainly women in Boston, to form a chapter. It was put on pause during the COVID-19 time period, but I do hope that we, in the US, we have chapters in DC, in Seattle, in Georgia, in the Midwest. It would be really nice to have the rich community of global health in especially Northeast join us.
Thank you so much, Dr. Dodd. It was fabulous to hear about Women Global Health and your work and your efforts and advocacy there. I do want to invite everyone that's joining us. Carrie posted the CME information and contacts in the chat, and so feel free to follow up with that for CME and CEU. I also invite you to enter any questions into the chat, and we would love to spend the remaining few minutes we have here with Dr. Dodd with some questions. One that I wanted to sort of start the conversation with is, you mentioned France, but I would love to hear, are there any examples that of countries or organizations that have done this well from your perspective, and sort of best practices or good examples?
Yeah, so one key message is that gender equality work is always a work in progress. So I'd say that no one has truly achieved it yet. And the first place that most people go to is Nordic countries. And Sweden, for example, is known for having adopt a feministic approach to foreign policy, but also domestically, really making sure that no decision making is happening without really gender parity. So it's not just having any single gender driving the agenda. They were one of the first countries to pass paternity leave and actually mandating it so that if men do not exercise their right for paternity leave, they don't get the perks of salary incentives and other components. And they were the country that really sort of set the bar high quite early. But even in a country like Sweden, they are struggling with issues such as high levels of gender-based violence and pay gaps, and women being underrepresented in professorship. But one thing that Sweden is doing is they've ingrained it into their policies and mindset in everything they do nationally, but also what they do with all their foreign work. And that's something that, for example, the United States doesn't necessarily do. We don't have, we're very mismatched in what we're sometimes doing nationally and what we're doing globally, and very fragmented. But by adopting a feministic foreign policy approach, Sweden has really mainstreamed addressing gender inequities as using its government power externally. Countries that have just signed on, which are really exciting, is Mexico is one that signed the feministic foreign policy just this past year, and it'll be very interesting to see how Mexico, which is one of the few countries that's from a middle income background, approaches this. There's actually call to action for the U.S. government to adopt this, and I do know that they are exploring. It's the first time the U.S. government here has adopted a gender White House council that actually is not a volunteer group, but staff that are leading gender equality right within the White House, and every key leader or department in the entire government sits in this task force, and there's 2 dedicated full-time staff that are coordinating it. So we're really also looking forward to how this example works. And now going out of the government aspect, like WHO is one where it's a work in progress. And there the model has been one, the senior leadership is very committed, particularly when Dr. Tedros became the Director General of WHO, he made a public commitment to achieving gender parity and really working on gender equality. Women in Global Health was really pushing for this, and we actually were able to get all 3 candidates to make the 3 shortlisted to make some sort of public commitment, but his was that he would have gender equal leadership in his senior cabinet. And for the first time in history, 67% of his cabinet, most senior leadership posts were women, and also geographically diverse. But I'd like to say that the work didn't stop there, because while there was commitment at the senior leadership level, we have seen over and over again that at the department level or at country offices, the mindset is still requires transformation. And so that's where it's not just enough to have senior leadership commitment, but it needs to be supported and backed by creating enabling environments for leaders throughout the organization to drive this change at all levels. The organization also has adopted in their program of work for the first time targets on achieving gender parity in member state delegations, which is something the organization rarely does. They're guided by member states, but they don't necessarily guide member states. And it's quite fascinating how the organization is trying to transform the entire power of decision making as well. Other examples are global Gavi, which is the Global Alliance working on vaccines. They're signed up on a journey of gender equality over 5 years ago, and they've worked with lots of different organizations and an internal assessment process. So they've teamed up with a group that works on particularly addressing the pay gap, and last year they announced for the first time that they've closed the pay gap and has scored quite well. And the lesson there is that all of gender equality has many dimensions to it, and it's critical to identify issues, work on them, and not necessarily just begin with leadership. You can also begin with some of the deeper drivers of inequity.
That's great. Thank you. Thank you so much for that response. One other area that you spoke to was the unpaid work, unpaid care work. And I imagine that's a tough sell to try to both quantify that and reimburse that. Have you seen any progress in those areas?
Yeah, so one country that actually did this almost, overnight was Ethiopia. And again, a few years ago, Ethiopia is a country that has very high maternal neonatal child burden disease and mortality, and what they were found, and it has a very rural community, and they had, again, a cadre of what's called community health workers. And this cadre was not professionalized, and they were often compensated maybe by stipends or other incentives, but never living wage. And what Ethiopia decided to do overnight was formalize, again, it was the head of the government at that point and the Ministry of Health, their community health workers, and actually give them living wage. And that resulted in dramatic, over the few years, dramatic improvements in maternal neonatal health. And what they have actually done is now made it a profession where one can begin as a community health worker and then can have training opportunities, then go on to be nursing or more specialized. So not only was it giving living wage, and they've actually invested more in community health workers in COVID-19. Many countries are trying to depend on volunteer work, and that creates fragile health systems. We know that many nurses around the world, a recent global survey showed that it's estimated 20 to 30% of nurses will possibly leave the workforce as a result of COVID-19 because of the working conditions and the lack of protection and support. And yet we have an estimate of 40 million health worker shortage by 2030. So just shows you how much we need to formalize and support. And there's places like Brazil where they're on that journey to formalizing everyone in the community health worker aspects, but they've allowed them to create unions and start negotiating salaries. And that's been a really great progress. Whereas like a country like India, it's very dependent on community health workers that are basically volunteers, ASHA workers, extension workers, are not considered part of the formal health system, even though the health system often applauds them. They don't get benefits in case they get sick or have some sort of disability. They don't get access to they were struggling to get access to PPE and many other things in the very beginning, yet they were the women that were responsible for going into communities for testing, for education and vaccines. And they went on 1 million ASHA workers actually went on strike during COVID-19 because of the lack of support, and their minimum wage was $12 a month, which even by India standards is quite low and not enough for living wage. And so, again, and it's really unfortunate what's happening in India. I have family members myself, and it's heartbreaking to see the health system fall apart. But a lot of the health system has been built on inequities and gender inequities, and these women that are supposed to support it are obviously leaving as well because the incentive isn't there, and many other reasons.
We are at the end of the hour and can't thank you enough, Dr. Dot, for joining us and for all your advocacy and work. Incredible segue there at the end, speaking about community health workers as our final global health grand rounds of this academic year. Next month, we'll be focused on community health in Uganda. So we invite all of you to come back next month, and we hope to see you there. Thanks so much, Dr. Dodd, and everyone for joining us.